Good morning, everybody.
Yeah, please go.
I take the opportunity to thank everybody, particularly Dr. Khanna, to give me this opportunity to present my humble achievements in front of this August gathering. Today I'm going to present hybrid management of peripheral vascular diseases, which I think is the future in managing increasingly complex peripheral vascular problems with minimal morbidity. I'm going to present a case of a complete iliofemoral occlusive pad. This is a 36-year-old male who presented in OPD with gangrene of the right leg below knee amputation stump, with fixed flexion deformity of the right knee and severe wrist pain all the way down from the right groin. Pain was not responsive even to high doses of opioids, which he was put on for 2 weeks from elsewhere. Right leg below knee amputation stump was done 4 weeks back in a different institute for ischemic gangrene of the right foot, which was extending beyond the ankle gradually over 3 months. He was a tobacco chewer and alcoholic, but not a smoker, never. He was suffering from severe wrist pain for the past 19 months with a history of severe claudication proceeding for another 6 months, and was deemed unamenable by many centers and hence was put on medical management along with anticoagulants. He was fit otherwise apart from borderline dyslipidemia. Clinical findings: his right leg was cold right down from the hip. In fact, just above the inguinal ligament it was cold as well. No pulses palpable whatsoever, no signals on hand Doppler all the way down from the iliacs all the way down, no signals. Right knee was in fixed flexion, severely tender right leg, anywhere couldn't be touched, couldn't be moved at all. And even his right hip was being held in flexion and the patient couldn't lie flat. This is the picture of the legs really. You can see the amputation stump with severe gangrene, bone exposed. And this is the CT angio. From the aortic bifurcation, if we try to look at it, practically there is no blood vessel on the right side, apart from very sparse collaterals. No patent blood vessel, no runoff really, on which we can construct a bypass or even an endovascular. So even a revision amputation was not possible without revascularizing because it would have the same fate. Hence, we decided to attempt a hybrid endovascular revascularization of the right leg with simultaneous revision just above knee amputation to rid the patient of this desperate situation. Accordingly, on 10th August 2010, he underwent the procedure. I exposed the right CFA-EIA junction with a right longitudinal incision. Following that, we performed an arteriotomy, and through the arteriotomy incision, did remote closed end arterectomy as far as possible of the EIA and also down the CFA and SFA to create a subintimal plane. And then along the subintimal plane, under fluoroscopic guidance, we proceeded with the endovascular route to create the new channel. So this is the first slide. As you can see, there is nothing. The wire has almost gone through the subintimal plane, just hasn't come back as yet. I had taken a radial route to confirm, and this is another shot from the iliac. There was a collateral which had become blocked, just proximal or rather distal to the bifurcation, which was blocked previously. Now there is flow in it. And now I'm coming back to the true lumen to make it sure I'm aligning up from the top and bottom so that I'm sure that we have got back into the true lumen. Then we can see that some flow has come back. We deployed a stent, Medtronic stent, bare metal. There was reasonable flow, but a bit of a hold up there because obviously at the bottom where I did my arteriotomy, I had the clamp. So it was not flowing away on the right side. Now, it was a very tight lesion, so the stent, I had to do a post-stent dilatation. And now this has happened. There was a rupture there with a leak, which I managed again deploying another covered stent with overlap at that point to close off the leak. but it was such a tight lesion that even the covered stent I had to again post-dilate. After that, we did an angio, but thought that there may be some residue, the atheroma or something there. So I took a balloon and gradually drew out, and small amount of atheroma dislodged, probably when I was coming back into the true lumen, that came out. Subsequently, we checked the flow, and it was good all the way. So now I started my procedure down through the endarterectomy channel, flow half through. This is approximately my target just above the knee. I want to restitute the circulation up to there. Then after another bout of dilatation, slightly better, still not going down fully. This is after some repeated dilatations, we have got down to the target lesion just above the knee. Target point actually, from where we can perform a refashioned amputation. And now it is reasonable. I deliberately didn't put a stent in the SFA because post-amputation he will be walking with a prosthesis which will subject it to a significant amount of shear and stress which can cause stent problems. So complications were very tight diffuse calcified lesions. Rupture of the junction of CIA and EIA was tackled endovascularly using overlapping covered stent graft. Dislodgement of atheroma plaque at the aortic bifurcation caused obstruction, particularly on the left side, immediately after this procedure, which again I had to open up on the left side and get the plaque out by a Fogarty catheter. End result was excellent. He underwent a successful revascularization, and the right leg just above knee revision amputation was done within 24 hours. He mobilized with the 4th post-op day on crutches and went home on the 6th post-op day, aka stump wound healed within 15 days, and he started prosthetic trial. Practically he is now completely walking normally. This is at 6 weeks. The wound is completely healed, he is fine absolutely. So from this I feel that it's my feeling that hybrid endovascular revascularization is the way forward in managing these sorts of difficult pads which are otherwise almost untreatable. And results are very gratifying, recovery is very fast, reducing the morbidity, and I think if further technology is available, it will make our job easier as well. Thank you.
Very nice case. So it's important to present that because that means that before amputation you have to check if you can't do something. Never amputate someone
that's the thing.
If you don't do before to recanalize. Maybe you can recanalize 90% of all occlusion.
Actually, Mr. Henry, this patient had been to almost 6 or 7 centers. And unfortunately, everywhere it was deemed because there was no target vessel whatsoever. And I saw his previous angios as well. There was nothing below the knee that one could actually do a crossover or whatever. There was no options left for them. Even below the knee and trifurcation, there was no blood vessel. It's a very strange case. I did check him for any prothrombotic state. He doesn't have any prothrombotic state. I checked his apolipoprotein little a and everything. He doesn't have any of these problems. He's just borderline dyslipidemic. That is LDL slightly elevated, HDL markedly low, VLDL slightly elevated. But apart from that, he's not hyperlipidemic or anything. So that was the situation. And hence he was put on medications along with anticoagulants. But even with anticoagulants, he failed and he turned up in this situation. It was desperate for him because, and I explained to him that if I fail, then I'm very sorry, I can't do anything much apart from the fact that you are destined to a painful death. Because even if we had done a hindquarter, I don't think it would have been successful for him because there was absolutely no circulation whatsoever to the right hip as to either.
No, congratulations, because you prove that you have too many amputations, not only in India, but in Europe, in US,
absolutely.
Everywhere.
I think if we can apply some thoughts that surgically and combined together, this is a good example.
But maybe, I'm a cardiologist, I'm not a surgeon, I will try before by humeral approach, maybe contralateral, maybe you can do the same.
Yeah, but going down the
Yes,
entire way,
you
you
can.
don't have a
Yes.
vessel where you can land.
Yes, but
Actually,
you
it is
can.
all
You
blocked
can.
up.
You can. But your technique is good. No
Thank you,
problem.
sir.
Okay, Mr. Chairman, we have run
And
out of
also,
time for
can we-
this
yeah.
paper. We'll move on to the next presentation. Thank you, Dr. Chatterjee.
Thank you.